expulsion I will show you, you start thinking that it's a sepsis. And routine childhood illnesses are excluded first, inborn errors considered only secondarily, and unfamiliarity with the biochemical interrelationships. That's the reason I will talk a little bit on the biochemistry of these ones, and inappropriate and unfamiliarity with biochemical interrelationships and diagnostic tests, because many of us are not aware. Inappropriate sample collection, that's very important. And more important is that to send the samples within 30 minutes, not later than that, and inappropriate sample storage. Every child with unexplained neurological deterioration, metabolic acidosis, hypoglycemia, inappropriate ketosis, hypotonia, cardiomyopathy, and hepatocellular dysfunctions and failure to thrive. And here comes that human brain is like a parachute. It works only when you keep it open. Otherwise, you will not be able to think of it. And waiting until sepsis and other more common causes are ruled out is not always advisable. At the same time, not every sick child should be thought of a metabolic disease. Unfortunately, the radiology has progressed a lot in our country, but the biochemistry has not. The reason for that is that maybe what I feel that if you do an MRI, you get a plate, a big plate, and when you do a biochemistry investigation, many of them are not rewarding, and you get just a piece of paper. And biochemistry has not developed in that way. And positive reports are not always percentage, maybe around 10% cases. And metabolic conditions are not visible, but whether mild or major, the effects on a family can be devastating. Like metabolic conditions, I'm a diabetic, and no one understands that what is going on inside my body. But I know what is going on inside my body and what a devastating disease it can be. Now, this child, can you diagnose this child? What has happened to this child? See, such a good looking and with a light colored hair and light colored eyes, and the parents are very happy that the child looks very like a Caucasian. And this is the story of Paul Bach. Paul Bach was a Nobel laureate. He received Pulitzer in 1932 and Nobel in 1938. And she wrote, I remember when she was only 3 months old, she lay in her basket on the sun deck of a ship. I had taken her there for the morning air. The people who promenaded on deck often stopped to look at her, and my pride grew as they spoke of her unusual beauty and the intelligent look of her deep blue eyes. Remember that. I do not know at what moment the growth of her intelligence stopped, nor to this day why it did. She was in China at that time. No one could diagnose that. She moved to USA, and even then in USA, it was couldn't diagnose till it was diagnosed in Norway. And she was given a urine of a patient of phenylketonuria. Yes, she said, yes, this is the smell that my child used to have, musty or mousy smell that used to have. And this is the most common cause of metabolic disease. The one I have showed you is a phenylketonuria, where you have the light colored hair, light colored eyes, and eczema. And it's the most common, and phenylalanine hydroxylase is the one which is important. And as a result, the tyrosine decreases. And you know that with all the pigmentation, tyrosine is very important. And it's a silent disease, and it causes permanent damage to the brain. And the clinical presentation I have shown you already in that: fair skin, fair hair, eczema, light sensitivity, hair loss, intellectual disability, musty or mousy odor, epilepsy in 50% of the cases, eye abnormalities, and hypopigmentations. I have highlighted restrictions because this is an MCQ question for the postgraduates, that phenylalanine restrictions is not a phenylalanine free diet. And I remember the first case of phenylketonuria way back in 1980s. I totally restricted the protein because there was no diet at that time, and the child ultimately died of protein energy malnutrition. Tyrosine supplementation is necessary, and tetrahydrobiopterin or BH4 may be necessary in these cases. Now, as these children with phenylketonuria grow, they can be pregnant also, and there is a problem with in the waist of the maternal phenylketonuria syndrome, and they usually have uh, problems during the pregnancy, like microcephaly, intrauterine growth retardations, congenital heart disease, especially left heart syndromes, hypoplastic left heart, and coarctation of aorta, and they have intellectual disabilities. This is the first case of inborn error of metabolism. After I came back to this country, I faced with, I was involved, and it's a case of sepsis with convulsions. Every time IV fluid was started, the convulsions stopped and the child was looking normal. We couldn't do much about the child, but we know that this is an inborn error of metabolism where they cannot tolerate the protein feeds in these cases. Of the term infants who develop symptoms of sepsis without a known risk factors, as many as 20% have an IEM. Remember that as many as 20%. If your unit is very clean and if it's a full-term baby, don't think of always that it is due to sepsis. This is a teenage female presents with one-day history of lethargy and first-time seizure, which is generalized tonic-clonic. She usually avoids protein in her diet, but yesterday ate chicken. Her past medical history is remarkable for migraines. So this is quite common. I mean, not common, but this can be a presentation which is like a common presentation of a migraine. Now, what is the most likely diagnosis? Now, diagnosis was not clear till the serum ammonia was done, and it was 420 microgram per deciliter, and ornithine transcarbamylase ornithine transcarbamylase deficiency is the diagnosis in this case. Remember that ornithine transcarbamylase is a X-linked disorders. So in females, it can be mild to the extent that it can be like a migraine only. Now, it is always a neglected topic, as I have told you. See, the electrolyte disorders are 16% of the seizures below 6 months, whereas inborn errors of metabolism are also 16%. এটা একটা স্টাডি থেকে তোলা হয়েছিল, but it is not uncommon in the Western country. I have tried to find it out, but it is not. I have not made the slide. I have not made the slide, but I tried to find out from the images.
I don't think that anyone is agree on that. That our পরিমাণে ইলেকট্রন তার থেকে বেশি আইএম পাই। এটা তো আমাদের যেটা ইন্ডিয়ান ডেটা,
এটা ইন্ডিয়ান ডেটা নয়, এটা ইন্ডিয়ান ডেটা নয়। It's anyway, whatever it is, inborn errors of metabolism are neglected ones always because you don't think of it. Now, incidence is overall 1 in 9,100. So that means every 3 cases of congenital hypothyroidism you are supposed to diagnose an inborn error of metabolism. But do we? These are the studies you can have, the figures and the Journal of Pediatrics 2002. And organic acidureas are 1 in 20,000, urea cycle 1 in 40,000, and fatty acid oxidation is 1 in 91,000. See, fatty acid oxidation disorders can present as a sudden infant death syndrome. In your NICU or at home, sometimes they have the SIDS, and we don't know what is the cause. It might be a fatty acid oxidation disorders or MCAD in some cases. And there are more than 750 inborn errors of metabolism now. And neonates are the most difficult one because 40% of them present during the newborn period, then 30, 20, and adult 5 to 10% of cases of metabolic diseases can present in adult also. Just like I was discussing with the juniors yesterday that the celiac disease presenting as an ataxia in an old age person. Or at 45 years, I have diagnosed celiac disease presenting with only anemia. Now, this is the incidence I have already showed you, but again, what are the common metabolic disorders that you see? See, the mitochondrial disorders are the one which is most common. And how many times we do the mitochondrial investigations? They are the 23%. And the next ones are the nitrogen containing disorders like amino acidopathies or urea cycle disorders. And these are the nitrogen nitrogen containing products. And the others are disorders of glycolysis and others. Now, there are some X-linked recessive. You need to take the history that ornithine transcarbamylase, as I said, X-linked recessive. So in females, they will present in a very subtle way. Fabry's disease, we have missed. One of our child was admitted, and the child was always complaining of the pain in the fingers and limbs. We didn't think of Fabry's disease only the day the patient wanted to take away the child. I said, can it be Fabry's disease? Because that's the presentation, that shooting pain, and you can't see anything. And because our orientations about the Fabry's disease is not there in children, so we didn't think of Fabry's disease. But we did think of, but after the patient was taken away, and we couldn't contact them again. Pyruvate dehydrogenase is one. I will show you why pyruvate dehydrogenase is an important one. Autosomal dominant, Marfan syndrome, alpha-1 antitrypsin deficiency. And it's an alpha-1 is an autosomal co-dominant. Co-dominant means if you are a carrier, you will present in a way, and if you are both parents are carrying the gene, it will again present. Just not like autosomal recessive, that if you are a carrier, you will not have any problems. And familial hypercholesterolemia, similar. It's a co-dominant, means one carrying will have a heart attack at the age of 35. If both the genes are being carried, they will present in the childhood at around 7-8 years of age. And mitochondrial disorders are the ones. IEM can present as embryogenesis, which affects embryogenesis. Why? See, the placenta can clear off most of the metabolites, but if any cellular metabolism is defective, like pyruvate dehydrogenase or cholesterol defects, where your mother will not be able to help you, so they will present as dysmorphism, like rhizomelic chondroplasia punctata. It's a perioxymal disorders. And perioxymal disorders cannot be cleared up by the maternal placenta, so they will have an intrauterine presentation. Pyruvate dehydrogenase, again, inside the mitochondria, pyruvate dehydrogenase works, and you will have the problems of pyruvate dehydrogenase again in the newborn period. Smith-Lemeli, it's a cholesterol metabolism defect where you have dysmorphism, syndactyly, and genital problems, and carbohydrate deficient glycoprotein syndromes. It can present as hydrospitalis. I'm not going into the details of that. And the 5 important steps are: suspicion is important, evaluation is important, and stabilization, specific treatment, and genetic counseling. I will not go into the details of the last 2 parts. So that's the important, that whatever you take, glucose, protein, or fat, all comes into the ATP. And if ATP metabolism is defective, it will cause the problem. And what happens? That the glucose is broken down to pyruvate by the anaerobic cycle. And after that, it goes into the aerobic cycle, into the Krebs citric acid cycle. And there, more ATP are being produced. And as you can see, the ATP is being produced here. And in the first step, anaerobic step, only 2 ATPs are gained. And here in this, when it goes into the citric acid cycle, 32 ATPs are being gained. And whatever the glycogen or fructose or galactose, it goes into the glucose, and that's important. And then fatty, when fat is broken down, it's long chain fatty acid, medium chain, and short chain. It's the medium chain fatty acid disorders are more common. Long and short are less common disorders. And this slide is important, as I was saying, that the medium chain disorders, medium chain fatty acid can go straight into the mitochondrial membrane without needing any carnitine for this. But whereas long chain fatty acid disorders, they will need carnitine. Long chain fatty acid will need carnitine to be combined with acyl carnitine and to go into the beta oxidation and cyclic acid cycle. But fortunately, long chain fatty acid disorders are less common. And that is what I was saying, that glucose, it goes to pyruvate. If it cannot go into the citric acid cycle, it will go to the lactate and it goes into the lactate rise. Whereas fatty acid goes into the beta oxidation I have shown, and then it goes into the acetyl coenzyme A and goes into the Krebs cycle. Amino acids, the alanine is the one which takes you from the amino acids. Alanine is the one which is produces a glucogenic uh, amino acids of like pyruvate, and then it goes into the citric acid cycle. So whether it's protein, whether it's a glycogen or the fat, whatever you see, fat, glycogen, and protein, it will all ultimately come to acetyl coenzyme A, then Krebs cyclic cycle, and then coming the ATP. And that's important. And acetyl coenzyme A are the precursors of the cholesterol. And so that is the reason in cholesterol and triglycerides. And you see, in case of glycogen storage disease or von Gierke's, you have hypertriglyceridemia. So with this, the biochemistry part ends, and the diagnostic clues are consanguinity. And that's very important. I will show you a case where they are not supposed to be consanguineous. I missed that part in the beginning, and the diagnosis came after that. Excess male death, age presentations, birth, diet, and stress all can be a precipitator. The typical features in newborn: lethargy, poor feeding, apnea, hiccup, respiratory distress, recurrent vomiting, seizures, abnormal muscle tone, cerebral edema, and we have diagnosed one case of maple syrup urine disease just by MRI showing the cerebral edema, and diagnosis was there. So, poor sucking, what do? We upgrade the antibiotics. Respiratory distress, what do? We give more oxygen. Convulsion, what do? You give more of anticonvulsants, levetiracetam, and others, without thinking that this can be a presentation. And about 58% of them can be presented as jaundice also. And this is a study from Egypt, Aswit University Children's Hospital. There are two types of presentations in the newborn period. One, it can start with vomiting, acidosis, and circulatory disturbance. If it starts with vomiting, acidosis, and circulatory disturbance, it's an organic acidemia. On the other hand, there is neurological features right in the beginning, and then they are more likely to be a urea cycle defect or a glycine encephalopathy. And these are the major errors, inborn errors, presenting in the newborn period with acute encephalopathy. And as I have told you in the other day, that I remember it as MONU, is like molybdenum cofactor deficiency. If you have thinking that molybdenum cofactor deficiency, think of a low serum uric acid and elevated sulfites in urine. We cannot do the elevated sulfites, but low serum uric acid, and we can do an EEG to see the bus suppression. Non-ketotic hyperglycemia, we do think, we do discuss, but we cannot diagnose. Maple syrup urine disease and organic acidemias. And this is a bus suppression pattern that you see in so many inborn errors of metabolism. And so please do an EEG in these cases. IM can present to you as SIDS, and that's very dangerous. situation and you are blamed. You have seen the child little lethargic, and the day after the baby dies suddenly, and you have to be blamed that you missed sepsis. So that's again a problem. Fatty acid oxidation, as I said, fatty acid oxidation defects are the ones. Organic acidemias and defects of aldosterone and mitochondrial disorders are the others. Metabolic diseases can present as stroke, and out of that, most important is Fabry's disease. Fabry's disease because it involves the vessels which supplies the nerves. And so it's a type of vasculitis involving the vasa vasorum. Homocystinuria, organic acidemia, carbohydrate deficient, glycoprotein deficiency, MELAS and ornithine transcarbamylase can present. It can present as a heart disease, and out of that, mitochondrial respiratory chain or carbohydrate deficient glycoprotein deficiency or primary carnitine deficiency or POMPs also can present as heart disease. So these are the nitrogen containing diseases like fat, protein, and sugar. Fat goes into fatty acid oxidation defect. Protein goes into organic acidemias, amino acidosis, and urea cycle disorders. And then the other disorder comes in. So what you do, first you do a ammonia level, but usually we do, along with ammonia, we do the blood gas also. And if in the blood gas, if the pH is normal, then it is likely to be a urea cycle disorder. But by then you have excluded the sepsis. So that's what I'm saying here, that the infection has been excluded. And if it is not an infection, and if your ammonia level is high, then, but pH is normal, think of urea cycle disorders. If it is an acidosis with an anion gap, think of an organic disorders, acid disorders, or if you're all are normal, think of a amino acid disorders. But if it presents, urea cycle disorders usually presents after 24 hours. But if within 24 hours, if your ammonia level, এটা ইউটিউবে আছে তোদের আর আমিও দিয়ে দেবো তোদেরকে. If your urea is ammonia is high in the first 24 hours, then think of a organic acidemia or pyruvate carboxylase deficiency. And there is another condition which is called THAN, transient hyperammonemia of newborn, which is usually in preterm babies. Most of the neonatologists know about that, the THAN or transient hyperammonemia of newborn is the THAN, which presents within the first periods. And if you can diagnose, the prognosis is better. If you delay, then you are late. And if it is afterwards, if it is acidosis, as I said, it's organic acidemias. And if no acidosis, urea cycle disorders. I'm not going into the details of that. Now, most of the urea cycle can be managed with dextrose, 10%, early use of fluids, sodium benzoate, phenyl acetate, arginine, and dialysis, but not exchange transfusion. Remember that no exchange, but only dialysis can help. And chronic management, low protein diet, supplemental food, and phenyl acetate, arginine, and citrulline. And liver transplantation now is a better solution sometimes because of the long-term problems are not there of doing that dialysis and other medicines also. So hyperammonemia doesn't occur only in urea cycle disorders, but it occurs also in organic acidemia and fatty acid disorders. This is a very important chart. In case of urea cycle disorders, your ammonia level is very high. In fatty acid oxidation defects, it is less. In between is organic acidemias. Lactate is more in pyruvate dehydrogenase deficiency because it cannot enter the citric acid cycle. pH, urea cycle, as I said, it can be acidosis or it can be alkalosis, it can be normal. But in case of organic acidemias, it is always acidic. And pyruvate dehydrogenase, it is always acidic. Ketonuria, if it is low ketone in the presence of hypoglycemia, it's a fatty acid oxidation defect. And if it is high ketone, it's an organic aciduria. So this I have told you that you should inform the laboratory that I'm sending this sample within the 30 minutes. Proper storage, preferably in an ice box, has to be saved. Freeze and save all urine passed by the infant. Otherwise, if the child dies, you will not be able to do any test. This is one of my patients with methylmalonic aciduria long back in 2002. You can see the 2002, it was proved as a methylmalonic acidemia, and management is low protein, L-carnitine, and B12. The other is propionic acidemia, which I'm not going into the details. The organic acidemia, which we see more frequently, and within the last 1 year, we have seen 3 cases of glutaric aciduria, but unfortunately, none of the pictures has been kept. So I had to download a picture. And what you see in this case, that she has a dystonia. And this dystonia with this type of batwing appearance and the wide, deep Sylvian fissure is very characteristic. And sometimes, can you see this Sylvian fissure, which is so deep? So this is a glutaric aciduria. Maple syrup urine disease, again, you need to think of immediately the moment the term baby starts having respiratory distress or seizures, to think of this. And feeding difficulty, irregular respiration, that's very characteristic, irregular respiration. This is one of our maple syrup urine disease, was diagnosed by Dr. Deepankar Das by the MRI, and large amounts of ketones can be present in these cases because your DNPH test, phenyl hydrogen test, can be positive in these cases. There are several types. I'm not going to the details. And this is the MSUD diagnosed by Dr. Deepankar Das right from the MRI. We did the MRI for that, why the child is having seizures, but it was said that it is an MRI. And this is you can see that the leucine, isoleucine, and valine is greatly increased. And this is the milk that we brought from Dubai, and BCAD, branch chain amino acid disorders milk, but the child lost to follow up. It's very costly also. Metabolic acidosis with increased anion gap, it can be organic acidemias, and then you think of that lactate pyruvate ratio. Lactate pyruvate ratio is important because if it is not going into the citric acid cycle, the pyruvate lactate will be high. If it goes into, then pyruvate will be high. Hypoglycemia, you go for lactate and normal lactate and reducing substance. But if you have hypoglycemia within less than 1 hour, like hyperinsulinemic condition that we see in our newborn period, it's an hyperinsulinemic condition. For 1 to 6 hours, if they can tolerate the fasting, then it is glycogen storage disease. But if it's for 8 to 24 hours and after that they become hypoglycemic, it's a MCAD or fatty acid oxidation disorders. So some of the carbohydrate disorders, I will talk about galactosemia. Now, it's easy, whenever there is a jaundice patient and you are not finding a cause, you do think of galactosemia, do think of your hypothyroidism, because medically, if you miss galactosemia, you will be in trouble, and elimination of galactose in the diet for lifelong. You all know this, and see, look at this child. This child at the age of 4 months was referred to me by Dr. Mehrotra with one eye being operated for cataract in Hyderabad without a diagnosis. And before the second eye operation, they came to me and I said, this is galactokinase deficiency. And it turned out to be galactokinase in Bombay. Dr. Jalan, he diagnosed that. And that's the reason with that diagnosis, we got 10 lakhs rupees for our PICO. So that's the galactokinase deficiency. There are different types of galactosemias, epimerase deficiency, diurate type, I'm not going into details. This is very characteristic. You can see the doll faces and protuberant abdomen of glycogen storage disease or the von Gierke's disease. And uh, after giving glucagon, they do not produce hyperglycemia. But we do not do nowadays this test. We do the genetics test. We do not do the liver biopsy also. What is that? Cornstarch. Asymptomatic still cornstarch because the liver cirrhosis can be prevented. But again, once you have the cirrhosis, you need to reduce the protein. And as I said, that glucose 6-phosphate deficiency, so glucose cannot go, so it goes into uric acid. Uric acid is high, lactate is high, triglyceride and cholesterols are high. And this is the one, as I said, that we now go for the genetic test. And this child came to us with hepatosplenomegaly, and it turned out to be a Cory's disease, type 3, the Cory's disease. And this is one where cornstarch you need to give, but not in a high dose. Rather, you need to give high protein in these cases. The liver diseases we have already discussed, but only one thing that I have not discussed is the GALD or gestational associated liver disease, or which is called neonatal hemochromatosis. And this is the one I was talking of, that this child came to me with some bleeding tendencies. And as you can see in the hands also, there are some bleedings. Scrotal edema was there. And PT was very high. APTT was raised. Serum triglyceride was raised. VLDL was raised. And alpha fetoprotein was 65,000. And a simple test, though it can be raised in many conditions that we see, but if it goes up to 65,000, I know a case with ascites and liver failure, seen in fellow, but they didn't do the alpha-1 antitrypsin. I did it, and it was that alpha-1 antitrypsin deficiency, tyrosinemia type 1, and patient ultimately diagnosed. With the diagnosis, the next pregnancy, we proved it genetically. This is tyrosinemia type 2. This child came to our outpatient, and hyperkeratosis of the palms and soles. And there was keratitis, so much keratitis that I had a lot of difficulty for taking the picture because of the photophobia that the child was having. Richner-Heiner syndrome, or the tyrosinemia type 2. And that's only one case I have seen in my life. Fortunately, Dr. Rajiv Malakar was with me, and he also confirmed that yes, it is a Richner-Heiner syndrome. And it can present sometimes, type 3 can present as status epilepticus. One of the very rare pictures that you see is a adrenal calcification, and that is old man syndrome. And see the calcifications in these cases. This is a downloaded picture. This is a child where you can see that there is consanguinity of the marriage. Now, after the consanguinity, third degree consanguinity, you look at the child and you see that the fingers are arachnodactyly and contracture. There are main 3 conditions. One is congenital contractural arachnodactyly, which is Beal syndrome. This is homocystinuria. And in case of Marfan syndrome, you do not get this. You get arachnodactyly, but don't get the contractures. And this is the homocystinuria, which is homocysteine level was very high. And I'm not. And difference is, one is genetic Marfan syndrome, and homocystinuria. Chromosomes are 21 and 15. You know, Marfan is 15. This abnormal deposition of fat anywhere. You see this child with developmental delay, and fats are everywhere. And this I've seen in the outpatient. And then I have shown the pictures to All India metabolic meeting, and they said that yes, it is carbohydrate deficient glycoprotein disorders. Very unfortunate condition. This is the book from the Nelson. You can see picture from Nelson, and this is the pictures of our patients with these nodules formations, and then in the ears also, and the diagnosis by biopsy Now we can do a genetic test, which is an ASH1 gene on chromosome 8, but we did the biopsy of this lesion and it was confirmed that it is a Farber disease. Now, from the Farber, we go to the Fabry's, because Farber is a ceramidase deficiency, but Fabry's is an alpha galactosidase deficiency. And they have the periumbilical angiokeratoma corporis diffusum, and that causes the problem. And we missed one of the cases because in the early stages, we missed that. The self-limiting, self-biting Lish-Tahan syndrome is the one, hypoxanthine guanine phosphoribosyl phosphorus deficiency. And this is a diagnosed case, but was treated here for almost 6 months as cerebral palsy and in the surgical department till we were involved. And this child came to my outpatient. See, look at the teeth. Look at the hirsutism in the exposed part and look at the color. And this is congenital erythropoietic porphyria. And they will fluoresce while you are doing under the Woods lamp examinations. So congenital erythropoietic, this patient had an hemolytic anemia, mild anemia, but very mild hemolytic anemia and congenital erythropoietic porphyria. This is Wilson, all you know. I am not going into the details, but always think of, the poet says, eyes are the window of the soul. Especially the Dr. Kundu will say that. But I will say, eyes are the window to the diagnosis of various diseases like Wilson's disease. And therapeutic measures, I have told you, I'm not going into the detail. But as a resident, what you need to do for a dying infant or suspected of having autopsy, preferably performed within 4 hours of death, at least take some liver tissue. At least take some liver tissue. Blood, urine, CSF, no one can stop you whether they give the permission or not. Skin biopsy, filter paper disc for the newborn screen, and DNA extraction we can do now. Because what happens that when the child dies, they say that, no, we don't want to do anything. We don't want to. But later on, they come back to you. So keep the DNA, talk to biochemistry department, Dr. Shuruparai, and keep the DNA so that we can test the child afterwards. Thank you. I know it was little. I know it was little high, but না বছরে 3-4টে আসে না, আমরা ডায়াগনোসিস করতে পারি না সব কটা, আর সেটা তো মাত্র 12টা। There are 750 disorders. There are 750 disorders. 3-4টে যদি হয় তাহলে তুই ধরে নে 7টা disorders। হ্যাঁ 6-7। It's not uncommon. পাঠিয়ে দেবো, ইউটিউবেই পাবি, আমি পাঠিয়ে দেবো, দিয়ে দেবো। আরে আমি তো আর কিছু নিয়ে যাবো না, আমার তো যা আমার সম্পত্তি সবই তো আমি দিয়ে যাই। টিভির মেয়েটা তো ডিসেমিনেটেড টিভি, পেট থেকেও বেরিয়েছে, লাঙেও বেরিয়েছে, সিএসএফ করে নিচ্ছে।